Thanks for having me. My name is Calloway. I'm a fifth-year orthopedic resident here at Campbell Clinic, class of 2016. I'm going to be graduating in a couple months here. And I was the 2015-2016 recipient of the Moshi Award. And with that, I went over to Moshi, Tanzania. And so here's a little bit of the story from what I did over there. So like any good orthopedic presentation, we start off with a case. This is a 31-year-old gentleman, a little bit gory pictures, came in with this injury. He also had a broken forearm and a broken arm. And so we always ask what the mechanism of injury is, and in his case, it was actually a crocodile attack. So that's a lead into my time over in Moshi, Tanzania. Moshi, Tanzania is over in the southeastern aspect of Africa. It's at the base of Mount Kilimanjaro, and fairly difficult to get there, but overall not bad travel aside from the amount of flights that we had to take. Tanzania is about the size of Texas. They have a population of about 50 million. Their main language is Swahili, and outside of the hospital, almost everyone does speak Swahili only, and they do have a fairly stable government as compared to most other African countries. They do have wireless communication. We were able to go to a Verizon store fairly quickly, get a SIM card for our phones, and our phones were up and running, so communication was not a problem. Really everything was fairly cheap, including food. Our normal meals were a few dollars, and beers, either at a bar or buying them at the store, was about $1. Food, excellent overall. Since it's on the southeastern aspect of Africa, it's very heavily Indian influenced, so this was a whole fish curry that I had one evening. Obviously beer's an important part of the Tanzanian culture. Here are a few of the ones that we tried, and you can see based on a picture of what our favorite was. And a couple introductions, so the lady in the middle, that's my fiancée Megan. She's a pediatric ICU nurse over at Lebanon. She helped us out in the hospital and also went off on her own and was doing some teaching with the pediatric and medicine residents. And on the far left is Dr. Glenn Crawford. He's an orthopedic surgeon working out of Portsmouth, New Hampshire, and has been to Tanzania over 17 times, including for the past 10 years, has been going to Moshi for between 2 and 4 weeks at a time to work with the residents over there, and has really jump-started the health volunteer overseas effort in Moshi, Tanzania. That's a Calloway monkey. So transportation, taxi was one of the options. Here was a 50-minute taxi ride that we took that was about $21. You can also take a bus that's about 50 or 60 cents. This is a normal roadside stand along the roads of Moshi and nearby cities. There's also something called a dala, where it goes between two different locations. As you can see on the bus, there are two different locations there, and if you need a ride between those two locations, they'll pick you up. So this is when we first got into the bus. There were about 18 people, and at most, I think we maxed out at 28 people in that small bus. So Moshi, Tanzania is at the base of Kilimanjaro. It's right there. Population, fairly decent-sized city for Tanzania. Temperature is about what like Memphis is in the summers, humid all the time. It is the cleanest towns in Tanzania and one of the safest as well. So we didn't have bad views either. This was our road back to where we were staying, and most days Kilimanjaro was out for us to look at. This was the house we stayed in, our bedroom, living area, dining area, kitchen, and back patio. So we weren't really roughing it, so to speak. That's a blue monkey. So Kilimanjaro Christian Medical Center was the main hospital that I worked at. It's a referral hospital for over 15 million people. It's fairly new overall, and they have 630 beds in the hospital, but routinely have over 800 inpatients. So you can do the math in that situation. From an orthopedic standpoint, up until a few years ago, they would routinely have over 100 inpatients. At this point, with them operating more, they have between 60 and 100 inpatients. Everything is in Swahili in the hospital, so I would usually take a left when we got to this corner. That's a vervet monkey. So daily routine, usually wake up about 6 o'clock. There's about a 15-minute walk to the hospital. On the left is the drive up to the hospital, and on the right is an example of many of the termite mounds that were in the hospital grounds. So we started off in the morning with radiology rounds. The radiology resident would look at x-rays with us for the first half hour. That's a warthog. Then we'd go to morning report for about an hour and a half. This is very similar to what we do in the United States, where the new residents or the interns would present the cases, and then everyone would comment and figure out a surgical plan for the patient. And then there was obligatory breakfast and tea time after rounds. I put 10 o'clock in parentheses there because this would oftentimes spill over. And this is a picture of all of the upper level residents who I worked with. Then people would split off into different scenarios. A few days I worked on ward rounds, and these ward rounds are resident driven, and they're the most senior resident that usually does these is a third-year resident, so I led rounds a few of the days where we would go around to the patients, ask questions to the medical students, residents, and make sure that the plans were up to date on all the patients. And these usually lasted 4 or 5 hours. This is a quick example. I won't go through each of the individual injuries, but this is an example of one of the wards. There are 9 patients in the ward, and in short, all of these are serious orthopedic injuries, and all of these patients have either had surgery or are planning to have surgery. Those are baboons. So clinic was twice a week, and very similar to our trauma clinics here in Memphis. We would see about 100 to 130 patients with 6 or 7 practitioners at a time, and fairly efficiently done. This is their physical therapy department in their clinic, and here's their prosthetics department in their clinic. And that's a water buck. So another part of the experience with me working with so many residents is lectures. They don't have a set time for lectures like we do here in the U.S. So any lectures that are given are usually from visiting professors, visiting residents or staff. So I was able to give 4 lectures overall, 3 of those trauma lectures that were largely based on Dr. Perez, Dr. Weinlein, and Dr. Bloodloss lectures that they give us. I was also able to do what's called a Sawbones lab, so we were able to bring over a lot of orthopedic equipment. And so one of the afternoons we went over exactly what the plates and screws were for and how to use them. So this is me with one of the third-year residents showing him a new plate and a new screw construct that they had not worked with before. That's a jackal. So another big part of what we did was equipment organization. This is the screw caddy when we got there, and you can see there's several different types of screws, and rest assured that none of those screws are in the right category for their lengths. So we did a big equipment overhaul of most of their equipment, most of their orthopedic equipment to organize it. And during the evening time, we would spend a lot of time organizing screws into different containers so that they would be able to use them at a later time. This is a brief overview of what we exactly put together for them. So we added about 5 or 6 different trays for them, and in all, we probably subtracted some of their trays as well with the organization effort. On the left is a picture of some of the equipment that they've been using. That's a Charlie hip replacement that we would put in back in the 60s and 70s in the U.S. That's an Austin Moore prosthesis for a hemiarthroplasty, a half hip replacement that we would use probably in the mid-80s. And then this is just a quick example of some of the plates and screws and K-wires that we brought over to help out. That's a hyena. So their operating room or operating theater. Orthopedics has 1 room most days and 2 rooms on Tuesdays and Fridays. And realistically, their operating room runs pretty similar to what the VA does here. So cases usually will roll back around on time. And after 3 o'clock p.m., unless there's a special circumstance, there aren't any more surgeries that will be done. That being said, there were a few days that we operated until 8 or 9 o'clock at night. This is their sterilization room. You can notice all of the open windows on the right-hand side. And this is their walk-in sterilizer. This is their orthopedic equipment all on the shelf. The main thing to note here is that everything is wrapped in cloth, meaning that all of these trays have to be re-sterilized weekly. We wrap things in paper here in the U.S. and they last for a year or 2, but they only have cloth to wrap their sterilized equipment in. So it was very important for us to organize all of their equipment so that they would only need to pull 1 or 2 trays at a time and make them more efficient. This is an example of one of their operating rooms. And just in case there was a fire, they had their buckets of fire sand as well. Those are gazelles. So a couple of the operative cases that I did, and in red up top, judge not lest ye be judged. This is not an operating room. As you saw in the United States, we didn't have CR, meaning we did not have x-ray during surgery. We didn't have a power drill for the first week that we were there, so we were mostly using a hand crank. They didn't have a reliable tourniquet. They don't have orthopedic-specific staff, so usually one of the residents ends up being the scrub nurse handing the instruments to us. And there's, like I said, there was little to no organization of the equipment trays when we first got there, but that became better. So this is their normal setup for the operating room. A couple of cases that we did. This was a nailing of a femoral shaft fracture. And as you can see in these two pictures, it's just me working with the residents. And so I think that was a very important part of this experience was I worked with Dr. Crawford for the first couple of days, but after that, then I really went off on my own and worked with the residents. And this was our result. And this was a fairly straightforward case, but really talked to the experience and the importance of residents going over. This was an amputation that a patient had that had to be revised, and this is a 30-year resident on the left, and he was going to have to do this case by himself. So I was walking in the operating theater area, and he asked that I help him out in this case, and I was more than happy to help him out. So this is really a turning point in my experience that I transitioned to being one of the guys, being one of the residents to help out wherever I was needed. So that was the result. And those are in Paula. So lunchtime, this was one of the cafes that we would eat at, and realistically speaking, we were operating most of the day, most days, so this didn't happen very often. So most days, we were sitting in this is the surgeon's lounge. They had tea for us and white bread that they would call their finest Tanzanian white bread. So week 2, we started getting the power drill to work, and that was a huge difference. We were able to do things like plate a both bone forearm fracture in under an hour and a half, and the residents had never seen a case go this smoothly before. Some of their study tools, they have Campbell's Operative in the top center, and I think that's the 8th edition, and I think we're on either the 11th or 12th edition now, so a little bit behind. And then this is actually the updated Rockwood and Green Fractures in Children book that Dr. Beatty is one of the main editors on. Most of the residents also do have iPads, and with the help of Campbell Clinic and the publisher, we were able to get codes for all of the residents to be able to access the full Campbell's Operative Orthopedics. So this is one of the residents before we did a surgery looking at the upper extremity chapter from Dr. Perez in Campbell's Operative. And this was the case that we were reading about. This is a lady that had broken her arm and had not healed it in 8 months after she injured it. So we ended up using one of the plates that I had brought over, the screw tray that I had brought over, and using the technique that I was teaching the residents as well as some of their staff, we were able to get a great result. And talking with some of the residents since then, she's still doing quite well. We also had some free time, so I was able to play soccer with the residents and medical students a few days. And we also had some free time to explore the area. So this was the first weekend we were there. We went to Marangu Falls and saw a really incredible waterfall, only about 30 minutes outside of where we were staying. We also did safari the last weekend we were there. The first place we went was in Ngorongoro Crater, one of the more famous safari places in the world. It's an old volcano that became a caldera, and so you can see from edge to edge, it's about 1,800 feet from the base up to the rim of the crater. This is sunrise at the crater. And if this doesn't make you think of the Toto song, Africa, then something's wrong. So this is a good example of what we saw while we were actually on safari. Just animals as far as the eye can see, with wildebeest, zebra, and an elephant in the background. The wildebeest a little more up close, and then a Cape buffalo in the grass. Here's a black rhino. These are fairly endangered, so it was neat to see one of those. As well as a lot of lions and then flamingos in the lake in the background. Some more lions, hippos, elephant, and even a standoff between Cape buffalo and the lions. We also went to Tarangire National Park, where luckily it was the dry season, or this probably would not have been a crossing that we would have been able to make. And here we saw a lot of giraffes, as well as a ton of elephants, really more elephants than we could have ever imagined, even some baby elephants as well. And this is a male bull elephant who's about 14 feet tall. So my soapbox for this whole process is really this is an invaluable part of resident education and something that I think really needs to become more an integral part of our residency program. I'm the 4th resident overall to go, and I think each year we've made this a little bit bigger and a little bit bigger, and I'm hoping that this is really the stepping off point to be able to expand this first and foremost to more residents per year. I would argue that we need to allow more of our 4th and 5th year residents, if they want to go, to be able to go on this trip for around 2 to 4 weeks at a time. There's plenty of funding from Health Volunteers Overseas, which is the organization who I went with. Dr. Calloway actually used to be a former chair of this program and would go over to St. Lucia and help out. But as you can see, there are plenty of places throughout the world that need help and that have similar programs to the one that I went to with resident education, where our main job is to go over and teach rather than go in, operate on 30 people, and walk away with them left with nothing. The vast majority of my time was spent teaching, educating, rather than just going over to operate. With the quote at the bottom, obviously, is really the main part of this. Health Volunteers Overseas also has around $20,000 per year that goes begging for scholarships that just goes by the wayside. So even from a funding standpoint, there is funding outside of Campbell Clinic. The other big thing to note that it's safe. There was never a point in time that we felt unsafe. Even my fiance and I going on a side trip over one of the weekends where we pretty much got to experience another town, took a bus, took taxis, and at no point in time did we feel unsafe. So thank yous obviously to Daniel and Molly Shoemate for setting up this scholarship. It's been a huge boost to my resident education. I called it somewhat of a senior capstone because I had essentially finished out my residency, and this was a great test, both from a social standpoint, from an operative standpoint, to prove that I'm ready to go on to the next step. Also the Campbell Foundation and Campbell Clinic for their support. Drs. Perez, Rudloff, and Weinlein for helping me out with lectures that I gave, and also Dr. Harkis for allowing me to take a few weeks off of his rotation to go on the trip. These are the Crawfords, Dr. Glenn and Dr. Sue Crawford. They were absolutely instrumental in our whole experience. They showed us a lot of things that we would never have been able to experience otherwise. And also to the residents here, some of the other upper level residents. And a quick aside, the second from the left, his name is actually Brian Madison. He's South Sudanese and is doing his residency in Tanzania. He's going to be over in the United States for a conference in Washington in September, and we're currently in the works for getting him to Campbell Clinic for an observership both at the Med and Le Bonheur for a couple months starting in October. So that's a really exciting time for us to be able to start this, to hopefully start a partnership up, if not just between our program and the Moshi Tanzania program, but really getting our residents out throughout the world and hopefully bringing some of the other residents from other places to be able to experience Campbell Clinic in real time. So that's it.